Good afternoon, and welcome to the Methodist DeBakey Cardiovascular Journal webcast. I'm M.Quiñones, the editor-in-chief of the journal, and this afternoon our webcast is going to focus on the topics that were published in our fall issue of 2020, shown here, on quality and safety in cardiovascular care. Before going any further, just remind everybody that if you have any comments or questions you want to send to us, please go ahead and text DEBAKEY to 37607 and send us your questions or comments. So, when I trained in the late 60s and early 70s, we doctors were the big boss. We could do anything we wanted, and we thought we were always saving lives, but we were also sometimes doing the opposite. And we were very similar to pilots in the 40s and 50s, who piloted the planes and did whatever the hell they wanted and had a lot of crashes. So the airline industry finally got their act together and started to learn how to do things in a system way. And I think finally the medical industry have done very similar things. So a lot had changed from the days I trained and my early days in my career, and I think for the better. So when we were planning an issue for the journal, we thought that this topic of quality, safety in cardiovascular care had reached a certain level of maturity that it deserved a whole issue dedicated to it. And I could not have two better partners to do this with me as guest editors, but on my left, Dr. R.Phillips, and on my right, Dr. Khurram Nasir. So Dr. Phillips is currently the Chief Executive Officer and Executive Vice President of our physician organization, which is a title that looks like he's an administrator. But in a previous life, he was a real clinical scientist, had done a lot of great work in clinical trials, in hypertension and other topics. And in 2005, when he took a job as the head of the heart center in UMass, he was sort of quickly submerged into issues of quality and had to sink or swim, had to learn very quickly. And through the last 15 years, truly has become an expert on this area. So he has been a leader with us at Houston Methodist in helping us develop the right approach to take care of patients with good quality and safely. And on my right, Dr. Nasir, he's a real expert in cardiovascular prevention, data management. We recruited him from Yale, and he's currently our director of the Cardiovascular Prevention and Health Center. So with any further delay, I'm going to pass it on to Dr. Phillips and let him take over with Dr. Nasir. Glad to be with you guys here.
Great. Same here. Thanks very much, everybody. It's really a pleasure to be here among such distinguished colleagues. And today, what I'm going to first is introduce our panel, our authors, who are spectacular. We have Tom McGilvery, who is the Chief of Cardiac Thoracic Surgery and Thoracic Transplant here at Houston Methodist. We were fortunate to recruit Tom after he had a 19-year career at the Mass General, where he developed a reputation as one of the top cardiac surgeons in our nation. And he's here today to talk about how creation and maintenance of a culture of quality and safety is foundational in order to create and shift our focus to value and to be able to create the types of programs that Dr. Quiñones talked about with high reliability. We also have with us Dr. William Weintraub, who is the Director of Outcomes and Research at the Heart and Vascular Institute at MedStar Washington Hospital Center. And he spent over 35 years on translational work with outcomes and quality research with a special interest in healthcare economics and health policy. And he was a pioneer, actually he pioneered the development of registries in cardiovascular medicine. And also with us is Dr. Karen Joint-Maddox. She's Assistant Professor of Medicine in the Cardiovascular Division of the Department of Internal Medicine at Washington University School of Medicine in St. Louis, and also is Assistant Professor at WashU Brown School of Social Justice and the co-director of the Center for Health Economics and Policy. As a health services and policy researcher, she focuses on improving the measurement of quality and efficacy of physicians, hospitals, and health systems, as well as understanding the impact of policy on healthcare, especially value-based and alternative payment models. And she's also quite involved in reducing disparities in care. If you could go on to, oh, I have it here. Okay, thank you. So what, our issue really focuses on value. And, this actually, Tom McGilvery has this quote in his manuscript. And it's from Michael Porter from 11 years ago now. And I'm titling it that healthcare is a product, and that's a good thing. Mike talked about when he trained and when I trained, and frankly, I'd say, still very prominent that the physician is the center, and we center our care around the processes that we've developed for the workings of our physicians and our staff. But the real focus in any business should be around the patient and around the customer. So Porter says value should always be defined around the customer, and in a well-functioning healthcare system, the creation of value for the patient should determine the rewards for all other actors in the system. So that's why Apple is so successful. They're not there to make all of their employees particularly happy, although they do, but they're mainly there to make the consumer happy. Since value depends on results, not inputs, value in healthcare is measured by the outcomes achieved, not by the volume of services delivered. And shifting the focus from volume to value is a central challenge. And we'll be hearing about that today from all of our speakers. This is a little busy slide for you all, but this is the way that we think you have to have processes in order to get to value. So we focused here at Houston Methodist, and we also structured actually the this issue around these five, what we call the 5 rights, the right way to do it, of high quality and safe care. Number 1 being right culture, and you'll hear Dr. McGilvery talk about that, developing the culture of safety. 2 is right process. You'll hear Dr. Weintraub discuss how data-driven care through registries helps us develop those right processes that are evidence-based. Right setting, deliver care in the right place, at right time, right treatment, and then you'll hear right value, putting this all together by Dr. Maddox. And this all leads to developing the high reliability system. And those features are deference to expertise. So in a high reliability system, you defer to the experts who are on the ground. And we see that also as being the patient and the consumer. So we focus our work on that, and you'll hear about that today from all the other authors. Sensitive to operations, that you're sensitive to what people on the ground need in order to get their work done and rely on them. That you're a learning healthcare system, that you're always have transparency, you're not afraid to admit mistakes or to evaluate them, and you're going to be better tomorrow than you are today. That you're preventing failure and that you are preoccupied with that. We're always introducing new technologies, we're introducing new people, we're introducing new diseases. This year, well, I don't have to tell you about this past year. And reluctance to simplify. So if something goes wrong, we look upstream to try to understand what was the system issue that occurred. And Tom McGilvery talks about that in his manuscript, that it's usually the system that failed rather than the individual. And then we all need to promote resilience so that when failures occur, or when we try to we see things that didn't go right, that we have the wherewithal and the ways to get back on the horse and to keep doing our work. So, with that, we'll turn it back over to Mike, and
Yeah, so we will have now Tom.
Oh, I'm sorry.
Yeah, if
Tom's
you're
up
ready
first.
to roll, you're on.
I'm ready to roll. Should I share my screen?
Yes, sir.
Great. So it's really a pleasure for me to be with all of you this afternoon, and I was honored to be asked to participate in putting together this this part of the DeBakey Journal, and I'm going to speak a few minutes on advancing the culture of patient safety and quality improvement. And I think all of us know that the American healthcare system has a lot to be proud of. We've accomplished a lot, certainly in the last 100 years. But despite our many successes, there continue to be opportunities for improving quality, access, and cost. I mean, if you look at the hard reality, the United States, our healthcare system costs at least twice as much as other like countries. And despite that, some of our quality metrics in terms of health and care are not as good as countries that spend less on it. As a physician and surgeon that takes care of patients with heart disease, it's humbling to know that we have the second highest death rate from ischemic heart disease of like countries in the world. It's very expensive to deliver the care that we give in the United States. Cardiac care alone accounts for about $215 billion a year. That's an extraordinary amount of money, and it really is not sustainable. And as Rob said, we're moving away from a volume and fee for service care to a value-based care. So, I mean, what does that mean? Value is essentially, if you look at it mathematically, it's quality over cost. It's not enough to just provide high quality care. You have to provide high quality care at a reasonable cost. And in fact, they're not two independent variables. That complications, bad care costs money. The better care you deliver, probably the lower the cost will be to provide that high value of care. The Institute of Medicine came out with a very sobering report in the late 1990s, To Err is Human, Building a Safer Healthcare System. And they defined 6 aims of what the healthcare system, one of a culture of quality and safety, should look like. First of all, it should be safe. Patients should come to the hospital because they know it's a safe place to go, not a dangerous place to go. We as providers should at the very least not cause them harm. And as Rob pointed out, the idea that bad things happen because bad people do bad things to them, I think that misses the point of it's bad systems, not bad people. If we can create highly reliable systems, we can reduce the number of mistakes. Beyond safe, it needs to be effective. We need now more than ever to focus on and practice evidence-based medicine. The days of relying on tradition or personal experience to guide how we practice, that really isn't acceptable anymore. The care has to be patient-centered, needs to be timely. We need to provide efficient care, and probably the most importantly, we need to provide equitable care. Now, there are a number of different ways that people look at who provides good care. There are certainly at least 4 highly regarded consultant agencies that rank hospitals and healthcare systems. And it's interesting that none of them agree with each other. If you look at the statistics, there are over 700 hospitals that are stated to be in the top 100. And no hospital is rated as a high performer by all 4 of these ranking programs. And only 10% of the hospitals are rated as a high performer in one is rated as a high performer in others. And I think that, I mean, there's reasons for that, obviously. I think that they sometimes employ different methods and they focus on different metrics. So how do we define quality care? How do we define safe care? I think that many of us would say, well, like Justice Potter Stewart said about obscenity, even though I can't define it, I know it when I see it. But is that really true? Well, the social scientists will tell us that maybe that isn't true, that we all do what we do because we believe in what we do. And the low performers, actually, those are the people who are least likely able to identify that maybe they need to do a better job. Maybe that they don't have the tools to identify it to improve their performance. So I think that healthcare systems need to provide the tools for them, decision-based tools, to provide better care. Let's say the father of quality improvement was W. Edwards Deming. He was not a physician, but he is considered to be the architect of how we think about quality improvement in businesses. He was behind the Toyota and some of the other great industrial improvements in quality. As he said, without data, you're just another person with an opinion. That we need to, although medicine is practiced as an art, quality improvement, we really need to use the scientific method to look at and identify how we're doing to continuously improve it. And as he said in the system of profound knowledge, first of all, we have to understand and acknowledge that we work within a system. And that, like all systems, if you make a change somewhere in that system, there may be and probably will be unintended consequences. So it's essential that we all understand the system that we work in. With that, have to have a knowledge of variation. In that system, we need to try to reduce as much as possible variation, and certainly unnecessary variation. If there are 5 cardiac surgeons that are going to the ICU and 5 surgeons have 5 different ways of doing things, imagine how difficult it is for the nurses, for the technologists, for everybody to keep all that straight. And imagine how easy it is for any one of them to make a mistake while they're trying to remember all of that. The theory of knowledge, as I said, the practice of medicine is an art, but we really have to be scientific about how we assess and how we improve the care. And then once we understand how to move forward, how do we get everybody within the system to make that change? And so understanding and being able to lead change management is essential. Evidence-based practice, the body of knowledge, the science and the practice of medicine is continuously changing. We all have to be lifelong learners, and it's impossible to follow if we don't know what the current standard of care is. That should be the baseline by which we practice our individual professions. It's not prescriptive. In fact, many physicians chafe at the bit, thinking that just following a guideline takes away their autonomy. But in fact, the further we get away from practicing evidence-based medicine, the less autonomy we will be allowed to have as we move forward in the new healthcare system. The Deming cycle, I think we have to continuously and constantly use the plan, do, check, act cycle. We look at our systems and identify problems, and we're going to hear more about different registries and quality registries that we can use to look at our own specific performances, come up with plans to make changes and to implement them, to check and study those results, see if they've worked, and if they do, implement them, and then start all over again with something else. We're moving into an age that not only should we be aware of how well we're doing, the public is going to be aware of how we're doing. Certainly in cardiac surgery, we've been front and center in having our programs and our own names published in newspapers and online with our own individual outcomes. And I think that is the way it's going to go for all of medicine. And it can be very humbling to see how you are related to everybody else. Some people think it's inappropriate, but others would say that there really is a moral imperative to do that. If you're not functioning at a high enough level, the public, the payer, the regulators should know it. But we should use that information as a way to improve, not to go away from our mission, which is to take care of sick people. We should use it as a way to be aware of how we're functioning. There's a great article, and I'd invite you all to read this, Sacrificing the Future for the Sake of the Present. What we don't want to do is to try to make our numbers better by not taking care of the people who need the care the most. This is not about risk aversion. It's about risk identification and risk reduction. That, I think, along with understanding that there's always a way that we can do it better, that's the foundation of improving the culture of quality and safety. I'll hand it back to you, Rob.
Tom, thanks so much for that very erudite and inspiring talk. I really like about what you said at the end. It's not about risk aversion, but it's about risk identification and improvement and the care that we did. I didn't say it as eloquently as you did, but I hope you still got the point across. So we'll now move on to Dr. Bill Weintraub, and who will discuss the registries, which he's been instrumental in developing, and how they improve care. And we do want to encourage you to be sending in questions, and so that we can take them and have a very lively discussion.
Yep. Text DeBakey to 37607.
Okay, Bill, take it away.
He's muted.
Bill, I think you have to unmute yourself. You may be triple muted. Hey, Bill? Okay.
I think it's figuring it out. Okay, can you hear me now?
We hear you now.
Send me a
Thank
signal.
you.
Okay.
Twice.
Yeah. Okay, all kinds of tricky electronic stuff one needs to do here. Well, first of all, I want to thank my friends from the DeBakey Heart Center for inviting me to give this talk. It's a great institution. It's great to hear all of you this evening, and to be able to discuss registries a little bit. I think the talk we just heard really is a segue into how we can use data more effectively. I'm also very taken with what M.Quiñones said about things in the 80s in the airline industry. When I first got into this in the 1980s, it was astounding to me, coming out of physics, which I did, the extent to which people were doing things with really no idea what they were doing, with no accountability and no way of looking at their own outcomes. They would just sort of brag about it, say, "Well, I did 100 cases and everything went great." And there were some sentinel events that happened. I don't mean sentinel events in terms of things bad, but things that happened in the public space. In particular, there was reporting from New York State about outcomes of cardiothoracic surgery, and there was a firestorm because these data were not collected in clinical registries. They used the poor quality administrative data that were available at that time, and there was no correction for variability in the patients, and so the surgical community in particular was very upset, and that prompted them to develop the STS registry in the late 1980s, and that was really the grandparent of clinical registries. Now, I first got into this in 1992, and after some false starts, we really put it together in the late 90s. and created the National Cardiovascular Data Registry. Okay, so everything's going great except that the slides aren't moving. Oh, okay, here we go. Okay, so we started in 1998 with CAF PCI registry, which is still one of the foundational registries, and then developed a whole bunch more registries over a period of time. Hasn't been static. The PVI registry is now actually being taken over by the Society of Vascular Surgeons. The registries in the NCDR, which are today are probably the most important, or remain the CAF PCI registry, but also the SDS ACC combined registry for TAVR, the TVT registry. This slide is several years old, but the number of hospitals, the number of cardiologists is about right, but the number of records is actually much larger than this, several times this size. So these registries have become really, really huge. Now, what's really very important about these registries and why they can really work is using standardized definitions and standardized data collection. Now, Miguel got at this a little bit when he was talking about the airline industry, because they did not have standardized ways of doing things 50 or 60 years ago, and there were a lot of plane crashes. And the FAA and the airlines got together and really imposed standards on how they do things. And this has begun to carry over into medicine. We're not as far along as we should be, and we have not invested as much money in developing standards as we should. Nonetheless, these registries do use standardized definitions and standardized data collection, so they're all, in principle at least, collecting data in the same way. These data can then be used for benchmarking on quality and research on quality. Now, my view of the registries in the beginning is what they were really should be about was about quality, not about research. The research is very nice, but they're really about quality and how to improve quality, with the idea that we would work together either as one big team or as teams across the country to try and improve what they do. And the folks in northern New England really did this extraordinarily well before the development of the national registries, in which they had registries, but really what they did is they worked together to try and improve what each member institution was doing. And they looked over a period of time, and they attributed to the registry, which that kind of attribution is a little bit dangerous, but they said, because of our registries, our results have improved. So it's hard to know whether the registries have really done this, but we do know that results in cardiothoracic surgery, that results in interventional cardiology, that results of TAVR, and many of the procedures that we do have improved over time. We wouldn't even know that. We wouldn't even know reliably that things have improved if we didn't have these registries. So they're really very important to looking for quality, but also we do begin to use them for research over the last several decades. And the number of papers that have been written using these registries is now in the multiple thousands. And many of these papers have become standards in the field of how we look at outcomes. There are lots of challenges with these registries, however. This is not a simple process. There's uncertain data quality despite auditing, and all registries that are worth anything do have extensive auditing. But it's very difficult to audit all of the fields, including some of the most important ones. The other problem is missing data. I talk a lot about data and data quality and big data, and a big problem in that area is missing data. Now, if we didn't have registries, we'd be relying even more heavily on electronic health records for research purposes, and for quality purposes. And those data coming out of EHRs are far worse, with much more missing data. So the registries have improved this a lot by standardized data collection and trying to get people to collect data completely. Nonetheless, in any analysis is going to be missing data, and dealing with missing data is always a challenge. The registries are difficult to implement and difficult to maintain. when I've sat on national boards of registries, I talk to people about what does it take and how expensive is it to develop these registries? They say, well, you know, with the NCDR, our budget is $50 million a year. And I say, no, it's not. Your budget is over $1 billion a year, because that's the budget of the site, of what the sites are spending to collect data, to maintain the staff and implement these registries. And I can tell you that while we clinicians value this, we have to sell it to the C-suite that these registries are really important. Now, years ago, this was very difficult to do, and it's gotten better as I think the C-suite has understood that the registries are very important for looking at our outcomes and looking at quality. But they do get tired of it when we say, well, we need more registries. We need to look at a registry for this thing and that thing and the next thing. In my previous institution, at one point they said, no more registries. So we had lots of fights to convince them that there were certain registries that were really important. What I've been emphasizing that is an important thing to do with these registries, which we have not done very well yet, is build data collection into workflow. And to the extent that we can do that, we can really improve quality and make it a lot simpler for the sites to collect the data, and then we can move into other areas with the registries. So we can do it in a way that that merges with EHR data, makes the EHR data, and allows us more effectively and expeditiously collect the data that we think is be so valuable for quality. A very big issue is the use of registries for public reporting. Now, what did I say earlier? That I think the registries are about quality, and I really saw what we were trying to do is form groups of people that work together to over time improve quality, and use the example of the Northern New England group that did that. But it was really public reporting that kicked off the idea of the registries in the 1980s, as we looked towards public reporting that we thought was a particularly poor quality coming out of administrative data. And the public does have a right to know, and does have a right to see the data on their providers. But this is a very difficult thing to do. And I think that if we don't do it from the registries, now we saw in the previous talk public reporting coming from other sources besides the registries, but there's now also public reporting coming from the registries. And again, the SDS is leading in this, and I think is doing a better job than anybody else. And the NCDR is coming along. But no matter what we do with this, there's concern. First of all, there's concern over gaming the system. Everybody says, well, at my institution, we do great. We never have any problems with our data. Our data is perfect. But that guy down the street, their data isn't very, very, very good. So there's concern and a certain amount of distrust. To the extent that we really cooperate with each other, we can limit that. I don't think that's actually the most difficult problem with public reporting. I think the most difficult problem with public reporting is the statistical limitations. And I've heard eminent statisticians say, "Oh, it's no problem. We can do this. We can look at data. We can look at hospitals doing as few as 25 or 50 procedures of a certain type." And my answer to that is that's nonsense. We don't believe that in clinical trials. There's no reason we should believe it out of registries. And I've seen the statistical arguments, and I don't really think they work very well. I think that when we say we can really adequately look at outcomes of thousands of hospitals and many thousands of providers using registries, I think that the statistical problems of having small sample sizes and the problems of multiplicity cannot be overdone, cannot be managed adequately. Now, there's statistical approaches that people use, including very fancy ones, which I'm not going to go into. But all I can tell you is, having looked at this extensively, they're not adequate. This is not going to get better easily, and it's something that we're going to have to deal with in the registries for forever. So we want to use them for quality. They're going to be used for public reporting no matter what, whether we think this is a good idea or not. And it's something that we're going to have to manage as best we can. Public reporting is unpopular for both of these reasons. The providers who are not statistically well versed are more concerned about gaming the system. The people who are really sort of data gurus are more concerned about the statistical limitation. Whatever, public reporting is not popular with providers. Well, we don't get to just do things that we think are popular, that we think are right, and we're going to have to work with other stakeholders in the healthcare system and be prepared to have our data looked at. I think that using registries for this purpose is going to be a lot better than just allowing others to use administrative data and tell us how we're doing. We're going to be much better off being part of the process, recognizing its limitations. So registries, how to use them. Number one is for quality. Improve your own quality. Look at how you're doing in your benchmarks. Make yourself better. Work with your colleagues at other institutions to improve what you're doing and make it safer. I think we're all trying to do that. Two is for research purposes. The standard for deciding on types of therapy is going to remain the randomized trial. Registries are not going to replace that. Observational data is not going to replace that, but could be a counterpart to it. So quality and research, and then public reporting is as well. So these registries, these clinical registries, are really essential. They're really a most important part of studying our outcomes. Cardiovascular registries, including those for the NCDR, the American College of Cardiology, the Society of Thoracic Surgeons, the American Heart Association, Get With the Guidelines, have been leaders in this field. I think we're all aware that industrial registries have proliferated as well, and they've really contributed answering rather niche kind of questions about specific products. But they're never going to have the sort of large-scale impact that the registries coming from the national societies have. The statistical approaches, as I've noted at some length, are more complicated than are generally recognized, and we're going to have to deal with that. Registries face challenges due to difficulty in implementation, data quality, and expense. The data collection is not built into workflow, and I think that's a challenge that we're going to have to deal with as we make these registries better and make them work for us to a greater extent than they have to date. So registries are important. We've made a lot of progress with them. We've learned a ton, but we also have a long way to go yet. So I'll stop there. I'll turn the podium back over to my colleagues at Methodist. I'm looking forward to hearing Dr. Maddox.
Bill, what a fantastic tour over the last 20 years, just giving us the insights of the creation and more importantly, what you truly pointed out for quality improvement, how this registries gives us insights in the care gaps. More importantly, a huge aspect of performance reporting, public reporting, naming and shaming can also help us get to a point of where we can improve the quality. Now, what about if we turn the notch it a little bit up and say, what if we pay you to do a particular thing and you're more likely going to do that? Now, that seems to be a very sound economic theory, but I'm sure Dr. Karen Joint Maddox will have some different views and will give us more insights on what lies beneath the bonnet and whether pay for performance works, and more importantly, how are we doing on the value-based performance programs? What are the pros and cons, and what's the next step forward? Karen, thank you so much.
Thank you. Thank you so much for having me, Drs. Nasir, Phillips, and Quiñones. I'm really glad to be here with you and to offer a few thoughts on value-based payment. Let me get my slides up. Here we go. Okay. So I'm going to start with a little bit of level setting here to talk about some terminology. What are the new ways we're paying for performance improvement? When you hear a lot of these acronyms thrown around, and I'm going to level set a little bit on the two biggest buckets of these things that we talk about today. So the first is value-based payment models. That's basically just the new name for pay for performance. It's taking a fee-for-service structure, so saying we're going to pay you $100 for a chest X-ray, we're going to pay you $10,000 for heart failure hospitalization. But we're then taking that fee-for-service structure and making adjustments to it based on quality, outcomes, and cost. So you did a great job last year on your cardiac surgical outcomes. Instead of paying you $10,000, we're going to pay you $11,000. Or your hospital had some trouble last year on outcomes. So instead of paying you $10,000, we're going to pay you $9,000. Now, in reality, the bump ups and down are actually a little smaller than that. But I think it's illustrative to say that we're working within a fee-for-service structure and basically bumping up and down to try to give signals around quality and costs. Most of our hospital dollars are under these programs right now. So the Hospital Readmissions Reduction Program is a nationwide mandatory federal program, the Hospital Value-Based Purchasing Program, the Hospital Acquired Conditions Reduction Program. This is the alphabet soup of these government programs. But they really do cover the majority of the hospital payments that are made right now. And more recently, it's moved into the outpatient setting. So we see the Merit-Based Incentive Payment System, to give you another acronym, or MIPS, where we've now moved this value-based payment paradigm, again, bumping payments up and down a little bit based on cost and quality, into the outpatient setting. And that is likely also applying to most people listening to this right now. The alternative to that is the alternative payment models. And these are payment models that really start to disrupt the underlying payment structure. So instead of sticking with that volume-based fee-for-service architecture, we're now moving to something more like global payments or episode-based payments. So maybe instead of just thinking about the chest x-ray and the outpatient visit and the inpatient visit, we'll think about an episode of care, 90 days around a surgical procedure, for example, or around an admission for heart failure. Or maybe we'll move toward an entire year in something like accountable care organizations and hold an organization responsible for quality, costs, et cetera, over the course of an entire year for a population. So examples in this bucket, which are much less common, but which there's, I think, a push for in many circles, are things like accountable care organizations and bundled payments. Now, we can look sort of across what we know so far, and some of these are pretty new programs, and talk about some challenges. So I think the three big challenges to talk about, and these will overlap somewhat with what you've already heard, so at least we're all sort of on the same page here, are around efficacy, accuracy and equity, and then the sort of documentation, gaming, burden part of things. So I'll start with the efficacy. What do we know about these programs? So I'd say it's a pretty definitively mixed bag. Over the last number of years since the Affordable Care Act was passed and since these programs have been initiated and scaled, there has not been uniformly positive effects on outcomes. We've seen perhaps some efficacy from the Medicare Shared Savings Program, which is an ACO program, particularly among physician group participants. We've seen pretty neutral efficacy for a lot of things like public reporting and hospital compare, hospital value-based purchasing, or bundled payments. And we've seen mixed findings with potentially even some signals of harm for the Hospital Readmissions Reduction Program. Now, if we move to think about accuracy and equity, we can understand another set of core problems with these programs, which is that we use, as you heard previously, really inadequate data and inadequate statistical techniques to get a true feeling for what's going on at most hospitals. We use administrative data in most cases, which really lacks the clinical granularity that you need to capture differences in disease severity. We're looking at whether patients have kidney disease or no kidney disease. We're not looking at the creatinine changing over the course of a hospitalization. Most risk adjustment models also lack components known to affect health, like frailty, which is a huge issue in surgical outcomes and in medical outcomes as well, or social determinants of health, which we know impact outcomes across a range of conditions. And you can understand perhaps that putting suboptimal efficacy together with suboptimal accuracy can have negative effects on equity when you think about the hospitals that might serve those particularly high-risk populations. We also have difficulty in the sort of documentation sphere. We are vulnerable to gaming in most of these programs, I would say. You can change documentation to create improvement. And I certainly can't call out specific examples of that happening, but a little bit like the prior story, no one will admit to it, but everyone will say that the hospital down the street is doing it. And there's also, of course, a huge burden of collecting data. We've created sort of a quality industrial complex around people doing chart abstraction that really puts a tremendous burden on the healthcare system. So let's move now to some prospects for how we might improve these things through a value-based lens. Now, one of the first ones we could do and should do and are doing to some degree is improving risk adjustment through data science. So we need advanced computing power and advancements in machine learning to try to take the data that we have and use it in ways that we previously couldn't. So claims data are admittedly non-granular, but they could even be used better than they are. We could understand not just does someone have heart failure or not, but how many times have they been admitted for their heart failure in the past year. You can get a pretty good idea of frailty from claims data if you know who has a hospital bed or a wheelchair. We're really not taking advantage of the depth of information that is there, let alone moving into other data sources, which we should also do. So moving toward new models and new ways of thinking about data could help us better detect the clinical events and also these complex clinical characteristics. Ideally, we would be moving these programs much closer to how we think about quality improvement and safety from the first talk, right? So this sort of cycle of thinking about how data technology and interoperability and real-time feedback with quality measures could actually lead to quality improvement being driven by these programs instead of a post-hoc 3 years later, here's how you did on some measures. So really thinking differently about how we can integrate the ideas around quality outcomes and costs into clinical care and having that feed into a value-based payment program as opposed to sort of letting the tail wag the dog, if you will. And then finally, particularly for the purposes of this audience, thinking about where in cardiovascular disease we might need focused payment models or really innovative payment models. How can we think about delivering care to our heart failure patients in a way that's sort of recognizes the complexity of doing so, right? Focuses on heart failure management as opposed to episode or I guess clinical encounter-based billing. What would our patients get if we became truly patient-centered? And how can we build a payment model that makes that happen? So I think for all these, it's taking it back to how could we best serve our patients? Where do we want to get? And how can we design a payment model to help us get there? Instead of saying, how can we design a workable payment model? And then that may or may not help clinical care. And I think there's a lot of potential to use financial incentives and structural changes to improve quality, but only if we're intentional about it. So I will stop there and look forward to some time for some questions.
Thank you, Karen. For the brief time that you took, that was a wonderful talk. Thank you. So what I'd like to do is pass it over to my two guests here, because I'm sure you may have some comments and questions. Sure. Before I take over, who wants to go first?
So actually, let me go first. So, I'm curious, the last two talks, you both talked about how quality is not in our workflows and capturing it. So I'm curious, if we had a big sum of money and we said, we want to redesign our EHR or, do some way to, pilot something, what would you do?
Who would you ask?
Both of them. I'm asking Bill and also Karen.
Okay, yeah. So I'll start, and then I'd love to hear from Karen as well. I don't think this takes a vast sum of money. I think we can spend a lot. We can spend a lot of money, but I think that we just haven't done a very good job. We haven't worked through I'm seeing myself up here twice. Is everybody else? That's peculiar. But anyway. Okay.
High value.
High value.
Yeah, very high value. So I don't think we have done a good job of designing our EHRs. I don't think we've done a good job of integrating how we collect data in EHRs. EHRs were not designed for the practice of medicine. They were designed for billing and for administrative purposes. I love the way Harlan Krumholtz put this one time. We were off writing papers and thought we were doing research, while the administrators were off doing something really important. They were putting EHRs in place, and we didn't pay enough attention to what they're doing. And I think that that's very true. And we're still paying the price for that today. It is getting better. The major EHR companies are listening. They'd like to do better, but it's not good enough. And I think we need a greater focus on it. And I, I'm at MedStar is a leading institution. It's a leading institution in Washington D.C. It's a little bit like Methodist in that way in Houston, and yet I have a lot of trouble convincing administration of the need to really work on this, to put in the effort that would go into developing the informatics platforms that would allow us to integrate data collection to look at outcomes into workflow. I've also emphasized this to the American College of Cardiology and the NCDR, and they just said, we think it's beyond our scope. We don't think we can handle it. I think that's most unfortunate because we're asking people all around the country to do this. So I think informatics solutions need to come along. I don't think we can just take the data we've got and have very fancy statistical tools that Karen talked about and think that we are going to solve our problems that way.
So let me push you a little bit. So we scrape our data like all the time, in real time to look to see how we can present to physicians ways that we can save on, IV beta blocker versus PO. We tell them right away, $170, you're doing this, switch to the oral. We, have imaging stuff all the time saying, no, you got that image yesterday, you don't need it again today. So, and we have these, we're scraping all the time, but I haven't put any effort into scraping for this, but Karen, you tell us things that we might be able to do, because, we're entrepreneurial here, and you got a good idea, we'll go for it.
Well, in medical informatics is sort of a funny industry, right? So it's dominated by these huge players who have been very much in the business of making sure that we can bill, and they've done a terrific job of that. That's what big health systems are willing to pay for. And the user experience sort of layered on top of that really hasn't come. There hasn't, in my opinion, been enough pressure on these very small number of very large companies to open up some of their infrastructure for people to be able to build on top of that and to start doing the things that you're talking about. Epic is pretty clunky, but it's unbelievably effective at billing. And so being able to use that platform and now build on top of it to be smart about medical informatics, right? This is also an area where we've really underinvested in human-centered design and user experience. There ought to be a way in this day and age, if my 2-year-old can pick up the iPhone and figure out how to use it, there ought to be a way that a physician or a nurse or whoever using a medical record could have an intuitive experience. So I see that as a huge area for innovation. If we could put the financial incentives in place to make it happen, I'm pretty confident companies would make it happen.
Mm-hmm.
So, great discussion on this, and just adding to this, Bill, so you pointed out billions of dollars of maintenance of these systems, of these registries. I'll just push back a little bit on, do you think it adds any value? Now, are these systems legacy systems? Do we have to redo it again? For example, at Houston Methodist, if the idea is to improve the quality of care, and I'm just talking about prevention, for example, lipid management and getting people on statins and those with cardiovascular disease, getting their LDLs less than 70. Why do I have to rely on these large registries? Why not I invest at the back end of Epic, work with Caboodle, Clarity, have my own data scientists clear that, and create it in a fraction of the cost of what an NCDR would offer us for those quality measures?
So I think it's a process that needs to go on at both levels. I think we need local informatics to develop systems that allow us to collect data efficiently and look at our own outcomes. If we do that efficiently locally, we collect those data efficiently locally, then that great expense that nationally is much lower, because the real expense of running the NCDR is not what goes on at Hard House. The real expense is what goes on in the community, where we're asking thousands of hospitals and many thousands of providers to collect data. If it's built into workflow, then we could have the data for benchmarking almost for free and we can also improve quality locally. Mostly, what this needs is clear thinking about how to do this. Some investment, but a lot of clear thinking and the sort of the political will to make this happen.
Yeah, and one of the things I listening to you guys is that one of the things the registries gives us is a profile of the nation. And if we did what you're suggesting, Khurram, locally with our own resources, we probably could do a great job, but it would stay with us. So it would be harder for us then to export that to the rest of the community, at least initially. So I can see both being very complementary, because what the registries is giving us that landscape, that profile of what's going on in New York, in Texas, in the whole country. But it's always hard to get that information and put it in your own little hospital and make it function. I mean, I think that's what we really are challenging. It's still a challenge. That's why we recruited Dr. Nasir.
So Mike, just to add on that, I think so what needs is like-minded institutions on single, for example, APIC, sharing resources and codes. And for example, we mentioned Harlan Cromwell's. We are working with lots of health systems working together and trying to say, can we create such registries locally that you can share a network of systems that come together for benchmarking. But I truly think that the future is going to lie more into the EMR. I think so we have to do it smartly, we have to do it less costly, but of course we have to ensure that the standardizations that were implemented over the last 20 years, we don't lose that, because without that, without any benchmarking and standards, it then becomes harder to really interpret that
So
data.
I remember.
So here's one of the things I've said at the NCR board meeting and other board meetings as well. I said, if you value these registries and you want to continue them, figure out how to work with the EHRs and build data collection into workflow, or these registries will be supplanted by the EHRs, and then several large companies that Karen talked about will take over and will look at outcomes, and I think that there's real danger in that.
So 30 years ago, in the world of imaging, we were analog, and we were wrestling with videotapes and the movies, the cines, and all that. And the digital technology started to come in, and every company had their own way of doing it, and it was a disaster. And luckily, all the imaging societies got together, put those guys in a room, and said, if you don't provide one standard, we're not going anywhere, and we're going to buy from you. And voila, DICOM was born. So why can't we have a DICOM of EMR? Why do we still have this provisional, thinking that each company has their own thing, and therefore the patient cannot share with anything? A hospital A cannot share with hospital B, et cetera, et cetera. I mean, why has it taken so long to get these companies to put them in a room and say, you create a DICOM, or we're going to basically just stop buying from you, or maybe just buy from one of you and not the others?
So we've let them get away with it.
Yeah, I'm not sure that the companies appreciate who the real customer is. I think that the rank and file physician, quite honestly, look at the registries more of a burden than as a benefit. It's something that they are required to enter data into, but they don't necessarily, as an individual, get much out of it. I think that the future of registries are to make them more interactive, so that the individual physician and surgeon can enter data in and easily get data out to see how they're doing in real time with their real patients, and benchmark that against or with their colleagues, so they can use that information more effectively and more efficiently to take care of patients.
Great thoughts. So this is where we would be having more fun with doing what we're doing right now than with the actor talks, but the hour goes fast. So I think we are right at the time to thank all of our speakers. You guys have been great. And as the editor-in-chief of the journal, I have a big debt of gratitude for all of you for contributing to the journal, and of course to these two giants that took over the issue and put together a wonderful issue. So thank you very much, and thank you for our viewers. Tomorrow, we're going to have another webcast on the issue we had in December, and that was on digital health. All the new gadgets, all the new ways we have, and how is that infiltrating medicine and importantly cardiovascular care. So thank you very much, and good evening to all your viewers.
Take care.
Hey, take care.
Bye-bye.
Thank you so
Thank
much,
you so
everyone.
much.
Have a great evening. Bye-bye.
Bye-bye.
Great seeing you.